are certain patterns in these very large data sets that humans, put simply, can't see.
Definitely.
It is going to be possible to look at these very large data sets and infer certain predictable futures from them. And so just interested to what are you seeing in some of the data?
Yeah, I mean, I completely agree with a lot of what you said there. So I definitely think that the trying to do everything in the big system of record isn't necessarily the right answer. If you look at the way that most private companies work, you actually have lots of different tools you use for different things because they have different specialisms and they all integrate and work together. And I think that's the critical bit. And I also agree with you on the point of sort of agentic abundance. I think there's a lot there. Interestingly, I think that the framing is so certainly the agents allow us to sort of make phone calls in and out. And one of the things that we've built and are finding significant market traction for is simple things that would previously be done in an outpatient booking center being done by an agent. You can cut through a lot of the work using that. But interestingly, many of the activities don't require an agent, so you can do sort of basic outpatient preoperative or remote monitoring, actually using relatively old-fashioned technology like a text message or a website. Where the agents become really powerful, I think, is helping the people, whether they're clinical or managers who are running the service, to identify those people and to find the person that needs help. And as you say, to do the predictions. And certainly we've seen, so we've done 160 million NHS episodes on our platform now. We've got billions of rows of data in the data set, and we are starting to see some interesting patterns. First thing we built was the AI tools to predict non-attendance in clinic. That's actually, it's a fascinating product, not just because it's incredibly accurate, looking at real people and predicting forward what their behavior is likely to be. But it begins allow you to run dynamic services. So dynamically adjusting your capacity based on those individuals, the current weather conditions, all of the things that we know happen, but putting those things into practice. Because it's actually relatively easy to do the analytics, I think. It's quite simple to build a model that says, when it's raining and I've got a certain cohort of people that live in certain postcodes, we know we're going to get high DNA rates. The hard bit is actioning that and turning all of that insight into something which is used as a day-to-day operational tool. And that feels to me like the opportunity area. Giving a general manager an agentic interface where they can use a natural language search to say, make sure that my cardiology clinics are full next month. And it goes and finds the patients and optimizes them and does that for them. Or a clinician who's looking after a cohort of patients, perhaps some of your transplant patients, and to be able to say, based on what we know about these people, who's likely to have poor drug adherence or who's going to need an extra intervention from me, and then allowing you to reach out to them. It's those agentic use cases that I get really excited about. And certainly when we started Dr. Doctor, the simple premise of do some patient engagement, allow them to do some booking, which would improve engagement, always worked, but was always the foundational layer. It was always the way in to begin to do kind of much more robust and exciting clinical change. And I think that's what the next few years look like. I think it's starting to think about a world where we have our EHRs, we have our systems of record, they're really well utilized. We have the data set, as you said, which is providing system value. But those EHRs aren't necessarily delivering huge day-to-day benefits to the people on the ground necessarily, beginning to then offer that benefit back down. So to say to a clinician or an administrator, now that you're using this system, here's an agent that can help you do your job day to day. And why don't we keep the low-value patients at home? Yeah. They save a trip. You don't need to see someone who doesn't really need you. And let's bring in the high-value ones, spend longer with them. I think that's our opportunity.
Yeah, because I think that's spot on, Tom. I mean, if you think about the operating model of healthcare, which is really disease care. But if you look at it, it's not that dissimilar from when I started at medical school, or even the descriptions in those books I read, devoured as a child. We tend to have patients coming to see us on a regular on some type of time-based sequence. They tend to come often with relatively little information transfer before they're seen in a clinic in any context, whether that's a primary care clinic or it's a hospital clinic. And very often the value to the patient of that time, if we're really honest with ourselves, is relatively low.
Yeah. And it's half a day out of work or a whole day out of work to travel to London and back.
And we're surprised sometimes when a new event occurs, when we hear about it for the first time in that visit. What about a world where actually we asked to care for people in their own, we care for people in their worlds that they live in, and we see them only at times when something about them is identified through them or through the data about them, that means that they're called at the right time for them to be seen with some information beforehand that allows that time they spend with a clinician to be of higher value to them, perhaps, than they're getting today. And it may be that, as you rightly said, there are 50% or maybe more of people who don't need to be brought in for what unfortunately is termed a routine outpatient appointment. I don't think we should use that language, but let's park that for a second. But those people that are coming in, there are fewer, but we're seeing them for longer, and we're able to holistically care for the many complex issues that person might be facing. And that just feels instinctively to me like a better future. Remembering that really the health or disease system is predominantly a system caring for people in ambulatory situations. So they're coming in from the world that they're living in, often to see a clinician for a brief period of time.
We walk through the doors of the hospital and we become a patient.
Exactly. Because really, health systems globally are the real business of those systems is managing that ambulatory care. Inpatient hospital care, either episodic or unplanned, is actually the minority of the care, health and care space.
Yeah.
It's predominant. And so how could we get to a much better data predictive model in the place where the majority of people experience their health and care?
Yeah, totally. And I think what's so interesting about this is, we've seen these sort of cycles in the digital health space over the last 20 years. And I don't think we're talking about a new world, actually. I think we've always been talking about empowered patients, giving people the ability to share more before they come in. I remember, right at the beginning of our journey, I learned about diabetes care planning. Remember, I'm an engineer, not a doctor. And so I went and got qualified in the year of care model to understand it. And the concept there of give people a chance to think about what's going to happen before they come in, share in advance with their consultant, and then you have a person-focused interaction, I think is what we're talking about here. But the difference is the technology now allows us to personalize that experience, scale that experience in a way that you never could before because of the abundance of agentic technology, and to proactively reach out to individuals who need help before perhaps they even need it. So I think what I find so interesting is I feel like the system thinkers amongst us have been describing this world for a while. And whether it's delivered through the voice agents, whether it's delivered through a different form of patient engagement, whether it's delivered through something we haven't even invented yet, I think the model has actually been static for a while. And it's the achievability and the scalability and the deliverability which has suddenly changed so much. Yeah. And then I also think that as the thing that's been missed here is, as a clinician particularly, not that I've ever had to run an outpatient clinic myself, it feels like we're asked to do more and more and more. And hopefully these tools can take some of the load off. Yeah. And I think that's one of the big changes as well.
And I think some of those tools that actually have only been in existence for the last couple of years. So it's not surprising we're starting to explore the way to best use these tools. I think can bring benefits to patients and people. Yeah, benefits to colleagues that work within health services, and ultimately benefits to the resources that we use, and therefore the sort of the economics of healthcare. Large data sets that we have at the moment, I think we need to start thinking about, how are we going to use those, really with a focus on those different types of future, better experiences and care for people, better experiences and working lives for the people that work within organizations, and better economic benefit. And I think if we keep those three things at the forefront of our minds as we develop these futures, then I think we will do well. I'm very optimistic about the future, Tom. Yeah, well. I think this is a fantastic moment. I keep, particularly this convergence of the biological revolution and the digital revolution. I often say to people, I wish I was 25 years younger, and then the less helpful of my friends and colleagues say, don't you mean 35 years younger, Ian? So that's a little bit tough. But I've seen the most incredible changes in my very fortunate career over many years, from times, for example, when if you had a myocardial infarction, a heart attack, there was nothing you could do. People were put into bed for 2 weeks and that was about it. Now to people having the most incredible technological and pharmacological care, and often having a procedure and going home either the same day or the next day, having had what would have been a life-threatening cardiac event before. So we've seen miraculous changes over those years. And certainly the changes we've seen in gene therapy would have been regarded as miraculous. Children now with genes repairing retinal defects that otherwise would have made them lose their vision, and those genes now restoring sight. So, and I think some of the things we're seeing from the data revolution, again, our ability to predict, infer certain types of disease events, maybe 5 to many years, and of course the ultimate goal being the ability to intervene in neurological decline, so in dementias. I think those things were all possible, but it's going to need committed people, both in the sort of companies that you're running, Tom, and in the health services, to work together to realize that future, because it's only actually together that we'll realize what's a very exciting future.
Yeah, I think that's right. And I think that's what we learned all those years ago when we started working together. It's working in partnership. Do you know what I find so interesting when you talk about that, Ian, is it has been a miraculous period in medicine. We can cure things which must seem, if you had a time machine and you traveled forward, you'd think that there'd been some sort of, dark magic here that we can cure some of the stuff that we can cure. But generally speaking, the equation has been it costs more. So we can cure all sorts of things, but there is a financial cost associated with that. And I think what we've talked about today is the ability for technology and predictive and agentic to begin to unwind that spiral, actually, and bring the costs down.
Well, I completely agree, Tom. I think the future is going to be very much one of precision, prediction, and prevention.
Yeah.
To increase health span, so the number of years that we live healthily, because actually for people, the ultimate goal is to have the best life possible for as many years as possible, we probably can't change some of the fundamentals of biology.
No.
But what we
Nor should we try.
But what we can change are the number of years of life lived well. We see some shocking disparities between the number of lives, number of years lived well in different parts of the country, and that's a lot of that is to do with economic inequalities and other types of inequalities. But what we've got to be able to do is to use some of the tools at our disposal now to overcome some of those inequalities and make sure that, to the best of our ability, everyone gets the benefit of the longest healthy number of years possible to enjoy life and to be active.
Yeah. I mean, what more could we ask for, right? Then I would certainly take fewer total and more active and high quality over. Just to sort of to close this out, because I think that's a compelling and exciting thought that we can do that and do it in a sustainable financial envelope with technology. Talk a little bit about the future of the NHS as we start to break down some of the barriers between providers, because that seems to be the conversation at the moment, is this concept of neighbourhoods. It certainly makes sense to me that the delineation between your primary care, your hospital care, your community care, and your mental health are relatively arbitrary, and starting to break them down makes sense. What's your take on that direction of travel? Is it right, and how do we cross over some of the difficult?
Yeah, I think they're completely arbitrary divisions, Tom, and they are, as you rightly say, they're sort of accidents and hostages of history, really.
Right. Yeah, they are.
Particularly the division, for example, between physical and mental health, totally artificial division. And I think we now recognize the sort of holistic nature of and the interactions between physical and mental health.
So often related.
And certainly the effectively there's the sort of what you might describe as the artificial divisions between different types of care being, for example, primary or community or in hospital or in certain different types of hospitals. Again, they are artificial constructs of the way that we've articulated a health system. They're not fundamental divisions. So, we do need to work hard to really scrub away those walls. Coming back to systems thinking, I hope I've for many years now thought about a systems of care. So hope I no longer think about sort of in hospitals and out of hospitals, primary and secondary and tertiary.
Single fields.
They are single fields.
Yeah.
And really thinking about the lives and journeys of the people that we serve, in that single field. And it's our job, I think, our duty to organize services around people that offer services, some of which have some distinct natures and distinct requirements, but to offer them in a way that is seamless to the individual rather than divided. One of the big things I think you and I have spoken about before is what you might describe as the value degradation gap that occurs each time we ask a person to cross an interface barrier between different services. And I strongly believe that, again, there are digital opportunities to make those transfers seamless. And we should be much better at data transfer to allow people to have a seamless passage. But all of those divisions, both between mental and physical health, between the different architectures of a health system as essentially designed and developed from the sort of late Victorian period, is not the one I think we want to see as we as we move into towards the 22nd century, and we need to be designing now a health and care future for the 22nd century, rather than replicating those of the 19th. And I think that's a fantastic opportunity for you and other colleagues at the moment, really to set your navigational course towards the 22nd century.
Well, I mean, what a thought. So to close this out, let's spend 2 minutes on trying to picture that for listeners. So we've set a course to the 22nd century. We've traveled through the constellation of lights inside of your father's computer. We've got EHR systems that are running. We've got data flowing, and the innovations happened. What does that health system look like?
A child born into the 22nd century would have some important information known to them and their families and about them from very early on. So, for example, the relevant genomic sequencing that would allow some of the risks to that individual to be known about, the tractable risks that one can do something about, known about quite early on, because some of the patterns of later life disease are set down in childhood, including the effects and the susceptibilities to environmental agents, pollutants, for example, and the world of epigenetics. And understanding, what are we going to, how can we set those early years up for success? And then as that child sort of ages, one would always hope in the most equal society that is possible, to try and mitigate the risks of inequality. And I think we have to recognize that inequalities drive a lot of the health outcomes for individuals.
Yeah. And health has such a great opportunity to drive social mobility in the inverse.
Exactly. For people to get, as they grow, care which is tailored for them, much of which could be the sort of coaching of behaviors and both for physical and mental health that are likely to be associated with the best health over time.
Yeah.
Understanding that people always have the right to choose, but one can coach towards better outcomes for people. And then when particular health and disease needs occur, that care is best delivered in the right place at the right time with the right information for people to get the best outcome that they would wish with the best economic use of resources. And that equation, if fulfilled, I think would be sustainable. And then to live into later life with as few complications of the human condition that are possible.
Yeah.
And then to have a good death.
Yeah.
And I don't think it's that much science fantasy to think that some of the tools that would enable that future are now in our hands. So by the 22nd century, Tom, I would strongly believe that type of future is possible.
Yeah, I mean, I do too. I think we have the technology, most of it, and it all comes back to the people. It all comes back to the people and the change. As we said at the beginning, it's a cultural problem, getting these things to happen. Some of it, I think, is a societal problem, and I think almost like the philosophy of what the healthcare service is designed to do becomes an important debate here. Do we believe in the ability of good prevention and good health and social care to create social mobility and growth, or do we end up in a situation where you end up with a more bimodal outcome for people and wealth reinforces wellness? I'm really hopeful that it's the former.
Yeah, and so I completely agree. And one thing that we haven't touched on today, but I think we did see in the COVID pandemic, for example, the exceptional amplification of inequalities on the impact of the COVID-19 pandemic falling unequally on our the people that we serve. And so I think that's probably what I would use the signal of the COVID pandemic as a rallying signal around how we design that better future.
I think that's a fantastic place for us to end on. The opportunity is there. Thank you so much, Ian. It's been, as always, fascinating, interesting, amusing, and enlightening in equal measure.
Well, Tom, thanks very much. It's been great, and I've really enjoyed our conversation this afternoon.
Fantastic.